Well, good evening, everybody. Why don't we go ahead and get started? Um, my name is Dr. Jeff Lancet, and I am the chair of the Department of Malignant Hematology at Moffitt Cancer Center. And I'm really happy to be here tonight to share with you this overview of innovations in malignant hematology. Um, and we have an exciting program tonight. But before we begin, just a couple of housekeeping items. Please be aware that this content is not intended to be medical advice and that anybody on the webinar should consult with their physician if they have any questions. And please don't rely on the information contained in this presentation for immediate medical needs. And if you think you have a medical emergency, call your physician or go to the nearest emergency room or call 911. And never disregard medical advice or delay in seeking care because of information contained in this presentation. So with that being said, like I mentioned, we're very happy to have you here tonight, and we have a very exciting program. We will have three speakers highlighting different areas of malignant hematology, blood cancers, and each speaker will give a brief overview of a certain topic that I think you'll find interesting. And then after we hear from the speakers tonight, you will have the opportunity to ask questions. And we invite you to ask questions by entering your questions into the Q&A box that's located at the bottom of your screen. And I'll be moderating the questions and highlighting them and asking the speakers to address the questions as they come in. We may also answer some questions electronically if we feel they're better suited for that type of a response as well. And with that, I think we'll go ahead and get started on this program. And I'd like to start out by first introducing our initial speaker for this evening. And this is Dr. Eric Padron. And Dr. Padron is the scientific director of the Malignant Hematology Department. He's a physician scientist with a lot of expertise, both in the laboratory and in the clinic, in many types of blood cancers, in particular myelodysplastic syndrome and acute leukemias. And he's going to be giving us a brief overview of a very, very interesting and relevant topic called clonal hematopoiesis, which is a precursor condition to many future myeloid or leukemic-like malignancies, and how we're evaluating this and potential interventions, including clinical trials. So, Dr. Padron, thanks for joining us, and the floor is yours.
Thanks, Jeff. It's my pleasure to be here, and thank you to the audience for joining. So, as Dr. Lancet mentioned, it's my pleasure to provide an overview of the efforts we're doing in our department to identify and potentially intervene in a condition known as clonal hematopoiesis. This condition will be treated within our department in what we call the CATCH clinic, so Moffitt's Counseling and Therapy for Clonal Hematopoiesis. So the premise of this clinic, and I'll talk about what clonal hematopoiesis is in a second, but the premise is that across cancer research, across cancer therapy, the most effective way to cure a cancer is to prevent it from happening. And because emerging evidence from here at Moffitt and other places have demonstrated that clonal hematopoiesis is really the precursor for most leukemias, our goal is to identify patients with this condition and to find patients who need intervention to prevent it from becoming a fulminant blood cancer. Because we're a cancer center, this clinic is really focused on cancer patients, but not necessarily cancer patients with leukemia, because that's what we're trying to prevent, but cancer patients with other cancers like breast cancer or prostate cancer, because we know that patients that have other cancers and patients who get chemotherapy or radiation for those cancers have a higher risk of leukemia. Next slide, please. So what is clonal hematopoiesis and how common is it? So at its heart, what clonal hematopoiesis is the observation that as we age, the same type of the genetic mutations we see in patients with leukemia are present in the blood of healthy individuals, and don't even know it. And you can go to the next panel. What's surprising to the medical community at large is that while these things begin to appear, these genetic changes in your blood begin to appear as we age, their initiation, so the first cell that acquires this genetic change in our bone marrow, generally happens in utero or in the first few weeks of life. These genetic changes stay dormant for a very long time, and then as we age, begin to expand. And it's that expansion that can lead to the complications that clonal hematopoiesis is associated with. Next slide. As I mentioned, clonal hematopoiesis is an age-associated genetic phenomena, so that if you're age 70, there's a 10% chance you have clonal hematopoiesis and don't even know it. If you're 80, it's slightly higher, and it keeps going up. And if you're under the age of 50, the chances are very small. But given this, and if you estimate the number of patients with clonal hematopoiesis in the United States, the total individuals in 2015 would be predicted to be 7 million. Now in 2024, we're thinking more 10 to 15 million people have clonal hematopoiesis. Next slide. So why is it important in general? So clonal hematopoiesis is widely implicated in human health. And in fact, I often say that it may be the most important biomarker of aging in humans. And so primarily and probably intuitively, you would guess that patients who have these leukemia mutations in their blood have a higher likelihood of having leukemia. And you would be right. There are too many papers to cite that demonstrate that this is the case. But what we do know is that only 5% of patients who have clonal hematopoiesis ultimately develop the full-blown leukemia. And that explains why there are 15 million people with clonal hematopoiesis, but a far smaller number of patients who have fulminant leukemia. But it opens a lot of research questions as to why 95% of people don't and 5% of people do ultimately get a blood cancer. But it's not just blood cancers. So clonal hematopoiesis has been very much associated with cardiovascular disease. In fact, certain types of clonal hematopoiesis put you at higher risk for cardiovascular disease than even smoking. It had been associated with severe COVID, stroke, osteoporosis, lymphoid malignancies. Every couple of weeks, there's a new paper. In fact, right before our meeting today, I saw one that was just published that connected clonal hematopoiesis to lung cancer and air pollution. And so, there is an innumerable amount of clinical conditions in which this is important. The one condition in which we think clonal hematopoiesis is protective is Alzheimer's disease, and there's really good science and biology done at Stanford to show how and why that is. Next slide. So while I think most would be convinced that clonal hematopoiesis is an important research area in cancer in general, why focus this? Or not only cancer in general, but human health in general. Why focus on clonal hematopoiesis? Why have a clinic in a cancer center? Well, first off, we know that patients with cancer, and this is studies first done here at Moffitt, have a higher chance of having clonal hematopoiesis. So at Moffitt, when we looked at it, 30% of all patients at Moffitt who have breast cancer, prostate cancer, lung cancer, et cetera, have clonal hematopoiesis, and this is age independent. So having cancer in and of itself puts you at risk for having clonal hematopoiesis. So why? So that's one reason. But why would this be particularly important in patients with cancer? So one is the obvious one, is to prevent a lethal leukemia, because we know that chemotherapy and radiation-related leukemia are one of the most aggressive and hardest to treat. But number two, one of the things that we strive at Moffitt is to have personalized or precision medicine. And what that really means is weighing all the factors in an individual person and based on the risks and benefits of any given therapy, make a personalized recommendation as to which therapy they should do, if any. And so because we know that certain clonal hematopoiesis mutations can really be fed by or expand by certain chemotherapies, we believe that knowing whether you have clonal hematopoiesis beforehand is really important, because it may augment the risk-benefit ratio of certain chemotherapies that are given to patients, for example, with breast cancer after surgery, in which it improves their chances of it never coming back. But if you balance that out with the potential risk of leukemia, some would recommend not to do it. And I'll present a case in which that actually happened. The other things is that it can help with cardiovascular disease and cardiotoxicity or heart toxicity from other chemotherapies. And so there's been links between clonal hematopoiesis and the toxicities that patients can have from chemotherapy. And then we want to have a clinic, because once we are able to identify who these patients are that are at high risk of getting a leukemia, how can we prevent it? How can we intervene? Without having a clinic, we can't start that process. Next slide. So who should be referred to our clinic? Well, we always think that it depends on the why. We want there to be an action that can be taken. So I'll give you a case of a young woman who action was taken. So this is a 39-year-old lady who herself found a breast mass. She received chemotherapy before surgery. And while getting this chemotherapy, she was referred to genetic counseling because she was so young. And incidentally, was found to have clonal hematopoiesis, because much of the genetic counseling studies start with a blood test. So she was referred to us. She had no family history, and her blood counts were great. Her blood levels dropped a little bit during chemotherapy, but that was expected and then returned to normal. And so when we repeated it with the definitive test for clonal hematopoiesis, we found that she had a mutation in a gene called P53, which universally is considered a high-risk clonal hematopoiesis mutation. And biology studies in the lab have shown that P53 mutations actually expand in the context of chemotherapy and expand in the context of the specific chemotherapy that she received. So we informed her that she had clonal hematopoiesis. Next slide. So after receiving the chemotherapy, we repeated the clonal hematopoiesis test, and in fact, it had increased a little bit. Everything was still normal. We did a bone marrow, it was all normal, so thankfully she didn't have the disease. But her breast oncology team recommended that she have radiation. And when I spoke to the radiation oncologist, they said that the radiation would hit 7% of the bone marrow. And so the question that a patient asked me is, should the patient have radiation, given that this is, high risk clonal hematopoiesis and could precipitate a therapy-related leukemia? Next slide. So one of the questions we asked is, there a reasonable alternative? Is it okay not to give further treatment? Is there a surgery that could be considered instead of radiation? Or are there any therapeutic agents that do not expand P53? And it turns out that there was an alternative, and that was to do a mastectomy. And so we informed the patient of the risks and benefits of radiation versus a mastectomy. She actually sought a second opinion, and they agreed with our assessment. And the patient elected, instead of doing radiation, to have a mastectomy. And she's doing well now. Next slide. So again, please continue. Next slide. Who should be referred? What we think is that all cancer patients who are undergoing chemotherapy or radiation with curative intent, meaning patients who have locally advanced cancer that is surgically resected, and chemotherapy is recommended to just prevent it from coming back. At minimum, we would love and are starting to help add to that personalized medicine that we strive to do by counseling them and screening them for clonal hematopoiesis. Next slide. So thank you for your attention. I think we'll hold the questions till the end of the session. I look forward to the discussion. Thank you very much.
Thank you very much, Eric. Great talk, great overview of a really important topic that's coming into its own, that being screening and prevention of blood cancer is something we really haven't thought about much up until recently. So really exciting field. And like Eric mentioned, we'll be taking questions after the session speakers have finished. So in the interest of time, we'll go ahead and move on to our next speaker. And we're fortunate to have with us tonight Dr. Ken Shain. And Dr. Shain is a physician scientist here in the Department of Malignant Hematology. He's also the co-leader of the Pentecost Family Myeloma Research Program here at Moffitt. Dr. Shain has a very busy clinical practice and also spends a lot of time in the laboratory studying the importance of drug sensitivity modeling in multiple myeloma. And I asked him to speak tonight about a very important topic in myeloma that has come to light over the past several years, and that being the advent of new immunotherapies in multiple myeloma, in particular bispecific antibody therapies and CAR T therapies, which are new immune therapies that you've probably heard of, as well as clinical trials in this area. So Dr. Shain will give us a brief overview of this topic. And thanks, Ken, and take it away.
Well, Jeff, thank you very much for inviting me and letting me speak to tonight. And then everybody who's listening, thank you for your patience and thank you for being here. I have the opportunity to talk about a pretty cool subject, and I kind of call it an evolution or a revolution in myeloma. So immunotherapies are really changing how we can take care of patients, and it adds to our armamentarium. And we've been relatively successful over time at doing a lot, really, really well in terms of controlling disease. We're not doing well enough. We need to keep going better and better and better. And this is a great kind of model of that. So really, we just want to talk about what's the changing landscape in myeloma, what are CAR T and T cell engagers at a high level, because we could talk for hours just about each one of them, how they applied in clinic, what are our next steps going to be, and then how are we also contributing to this evolution. And as you heard Jeff mention, the Pentecost Myeloma Research Center is really one way we're having patient-funded ways of helping us ask personalized questions about immunotherapy and other therapies. So really a stalwart in how we're taking care of patients. But essentially, myeloma is a disease that has a plasma cells. Okay, that's the cancer it is. It's in the bone marrow, and it produces this protein we can measure. And a course of myeloma goes from a pre-malignant condition, kind of like you were just hearing from Dr. Padron about leukemia. This is called MGUS, and it becomes smoldering myeloma, then active, and we can track numbers get up. And then once you're active myeloma require therapy, patients go through multiple lines of therapy. So successful therapy, relapse, successful therapy, relapse, and it gets more challenging to control disease as we go through things. And so we have challenges, the malignant transformation, leftover disease that leads to relapse, multiple resistance disease. And really we want to think about is how do we prevent this? How do we drive disease lower? And immunotherapy, which is what I'm talking about today, kind of right now is focusing on relapse disease, but really can affect every aspect of this therapy. And the most important thing is every one of you is an individual, right? So we need to figure out how to personalize therapy to you as best we can. Next slide. So immunotherapies are revolutionizing the treatment for myeloma. That's a safe statement to make. Next slide. So where we've been, and we are still, because not everybody has access to immunotherapies, but our current therapies for patients who failed all the major classes of drugs and have been exposed to all of them is really looking at clinical trials. New agents are giving us about a third of patients will respond, okay? At the beginning, 90+% respond, but by now we're down to 20 to 30%, okay? And then deep levels of response where we can't measure disease happens in 1 maybe 2 out of 100 patients. And then that lasts for only a handful of months on average. Again, these are averages. Some people less, some people more. So that's kind of where we are with traditional therapies in this group of patients where immunotherapies have been approved, and we're starting to look as it'll trickle down to newly diagnosed as we go. Next slide, please. So what are we doing? Where are we going? So we're going with immunotherapy. We're actually there already because we have 2 CAR T, chimeric antigen receptor T cell therapies approved in myeloma, one for a couple of years, one for over a year. And we have 3 T cell engager therapies or bispecific antibody therapies, one less than a little over a year old, and 2 were just approved in August of 2023. And essentially, what are these doing? These are therapies in which we can utilize our patient's own T cells, the cells that kill bacteria, kill bad guys, but aren't able to anymore when you have cancer. Is with CAR T, we can take them out of patients through a catheter. We can then essentially engineer them to target something that's on myeloma cells. And when they do so, they become active and kill better. And we can grow them all outside of a person. And then we put them all back in at one time. And it causes myeloma cells to die really, really, really fast and really, really well. Okay. There are toxicities when you put a bunch of T cells back in, but that's kind of what CAR T therapy is. It's our way of harnessing the immune system, the T cell immune system, and helping it work for patients. We kind of do most of the work outside of the person. It gets manufactured. So it takes time. T cell engagers or bispecific antibodies are the same concept, but they use the T cells that are in there, and they're more like therapy. So essentially, we have antibodies. And what they've done is stuck one that recognizes myeloma cells, that same target the CAR T recognizes, and another antibody that recognizes T cells, and it brings them together. So in you, it brings the T cells right to the bad guys and causes the T cells to start killing the bad guys. And they're both really changing. And what you'll see in a little bit is how well we can take care of patients. Next slide, please. So we just talked about having 30% response rates. Now looking at CAR T therapy, we're talking about 3/4 of patients now respond. Okay, with one, almost 98% with another. And they're deep responses, so meaning we can barely measure disease, there were 3/4 of these patients that respond in both cases, if not 90%. And then it lasts a lot longer, right? 3 times as much. If you respond, it's going to last almost a year with one. And in the other studies, still we haven't had 50% of people progress after 2 years. So again, not 5 months, months to years. Okay, next slide, please. And those are the CAR Ts. Now, if we look at the 3 bispecifics, the names are really exciting. You can take them out. I call them TEC, TALC, and ELRA. And essentially, they target something called BCMA, the same thing as the CAR T. And here you can see response rates in the 60 to 70% range, progression-free control of disease for plus a year, almost a year, so doubling to tripling the amount of time in control. And when you do respond, we're talking about months to years. Again, so in the same population, we're doing much, much better with these new agents. So very, very exciting for our patients again. And as we trickle them down to earlier lines of therapy, we expect them to be even better. Next slide, please. But we know myeloma is a disease of success and failure. That's because it adapts to what you're doing. So you got to keep building new blocks, new therapies to utilize. So those 5 aren't enough. 2 CAR Ts and those 3 bispecific antibody trials. Next slide, please. So just as an example, they have other bispecifics that are in clinical trials and close to being approved or a little farther along versus those that are less long, targeting the same targets, targeting new targets, so different things on myeloma cells. So now you can think about them as targeting something new after you fail one. So BCMA, something called FCRL5 or GPRC5D. Now you got to remember all these things, or I don't answer questions afterwards. But you can see they all respond in the same kind of level. Almost 3/4 of patients, 2/3 of 3/4 of patients are responding. So again, all these things are going to happen. That's what's now next. Developing new targets and new immunotherapies, whether it be bispecifics or CAR T to new targets or even 2 targets at the same time. Next slide, please. So what are we doing here? So translational research, again, really hinging a lot on what we call the PMRC, which is the Pentecostal Myeloma Research Center, is we do a lot of translational research based on the patients who donate their tissue, their myeloma cells, their immune cells, so we can figure out what makes you different than somebody else. And I kind of just put a few things that we published this year around that, looking at CAR T in different subgroups, looking at how we've actually just published, actually last week, how we're changing how we can individualize prognosis for myeloma patients using genetic sequencing. Okay, so pretty cool things. And then on the CAR T side of things, we have different groups and labs in this institution looking at developing new targets. So one group has looked at and identified a new target for myeloma CAR T, and we're starting to work on getting that put into clinical trials, upgrading it, developing it. Others are looking at maybe we can target two different things at once, okay? And then we have another group that's looking at maybe certain T cells are better at than others. We look at a subgroup, maybe they're better at targeting and killing bad guys than others. So those are things we're all looking for. And then just to kind of finish it up is we have clinical trials. And these are all immunotherapy trials. So T cell engagers are bispecifics. You know, we've looked at now a tri-specific antibody, looking at a different part of the immune system. We now have bispecifics in combination with traditional therapies like daratumumab and things we use all the time. On the way for CAR T, we have new targets, new constructs, new places to use them after transplant, okay? Faster production CAR T cells. And then what's coming up in the next few months, hopefully, is, again, tri-specific, multiple targets for bispecifics. We actually have a study opening where we're looking at bispecifics in pre-malignant disease, so in smoldering myeloma. Can we try to knock it out before we can even get to myeloma? And then combination studies. And then in CAR T, same kind of thing. Can we look at it in newly diagnosed patients or instead of transplant versus just the relapse refractory patients? And then can we develop new targets and they can be just as effective? So those are kind of things that are underneath our umbrella going on here at Moffitt and how we think we're contributing to this evolution and this revolution in myeloma when it comes to immunotherapy. So I'll stop there and please, we'll hold a Q&A until after, but we'll go from there. So I will stop there and thanking all the patients who helped us here tonight, all the patients who helped us with our research. And this is the group, the Pentecost Myeloma Research Center folks. Not everybody's in the picture, but it's tough to get a bunch of people in the same place. So I'll stop there and Jeff, let you move on to Dr. Pinilla.
Great. Thank you, Ken. Awesome talk as always. And really very cool to see so many new and effective therapies that are coming on the heels of, you know, already a revolution of effective therapies for myeloma. So just the fact that there's the ability to achieve good results with these new drugs after maybe so many other drugs have been tried and have done well for a while, but the disease comes back to know that the immune system-based therapies are so effective, and it's exciting to think about how they're going to be moved up earlier into the treatment plans and to better understand which patients are going to be able to respond most vigorously to these new treatments also.
Absolutely. Thank you, Jeff.
Work you're doing. So yeah, so I think what we'll do now is move on to the final speaker. Last but not least, I'd like to introduce my good friend and colleague, Dr. Javier Pinilla. Dr. Pinilla is also a physician scientist here in our Department of Malignant Hematology and is also the section leader for the lymphoma section, the lymphoid malignancy section here at Moffitt in our department. Dr. Pinilla has a special interest in chronic lymphocytic leukemia, but really in lymphoid malignancies in general. And keeping on the theme of immunotherapies, I've asked him to give a brief overview of novel immune therapies in lymphoid malignancies to include, again, antibody-based therapies and clinical trials in this area. So Javier, thanks for being here and go right ahead.
Thank you, Jeff. And once again, I'm happy to be here and I'm glad to be sharing with you some information about immunotherapy. Again, it's not a repeated talk after my dear colleague, Dr. Shain, discussed immunotherapy in multiple myeloma. Immunotherapy is really a very important part of what we are doing and definitely is in our hearts in the treatment of lymphomas. In fact, we were the first one who really used immunotherapy almost 30 years ago with what we call monoclonal antibodies against CD20. It was the first form of passive immunotherapy. However, differently what happens sometimes with some of the myeloid and even for sure myeloma, lymphoma is much more complex issue here because the lymphoma terms is obviously cancer affect the lymph nodes, but as you can see here, the frequency the lymphomas is very different, and I think this slide represents the different types of lymphoma. And this different type of lymphoma has different names. I'm not going to go in detail, but you can imagine that we call low-grade lymphomas, high-grade lymphomas, and things that are in between. And what does that mean? Right? We have lymphomas that really progress very slow and may never really require therapy. We see lymphomas who really very aggressive, and we will discuss in a second. We call diffuse large B-cell lymphoma. And we think things that kind of in between, that sometimes can be, very indolent or very aggressive. Maybe happen with SLL or small lymphocytic lymphoma, CLL, and some forms of, for sure, of mantle on other things. But I think that's the complexity of lymphoma, and obviously the fact that immunotherapy in the more all form of monoclonal antibodies has been used for many years. Next slide, please. So we're going to really concentrate as example in the more aggressive lymphoma is the diffuse large B-cell lymphoma, DLBCL. And here we tell you that definitely you see this R of the G associated with the CHOP. CHOP is the classical chemotherapy we've been using for 40, 50 years. But we really learned many years ago, more than almost 20, 30 years ago, that the addition of monoclonal antibody who target specifically the malignancy, the B cell that we are really discussing here, different from the myeloma, but we're talking B cells, they really have good outcomes. And we can cure patients, right? But in the next slide, please. The problem comes when the patients do not respond or they relapse. And then is what things are really start to really go down. And those patients do not have a very long survival. So for many years, we've been looking ways to really understand the biology of this condition, in this case, aggressive lymphomas, and try to implement new things besides the classical immunotherapy with monoclonal antibodies. So in the next slide, we really have another example of CAR-T. So CAR-T revolutionized, once again, has happened more recently in myeloma, but it was the first really approval in lymphoid malignancies, first in ALL, but also very shortly after in diffuse large B-cell lymphoma, mantle cell lymphoma, as well follicular lymphoma. Really completely changed the way that we see these patients who did fail classical chemotherapy and they were not cured. And again, my colleague, Dr. Shain really briefly review with you, and we try to really get these very good T cells, these kind of armor cells that our body has, really get them out of the body, put it with some really genetic manipulation that we put some kind of really receptor that recognize these B cells, expand them and put it back. These are phenomenal really strategy that has come out with really good data, as we show you in a second, but also comes with sometimes severe toxicities. And the toxicities come with this, sometimes come because this encounter between the T cells and the lymphoma cells, where they produce a very severe inflammatory reaction that we learn very well to manage, and we do manage in a weekly basis. However, also sometimes we encounter what we call neurological toxicities. So once again, very successful therapy with some toxicities. So in the next slide, we see that over the last years, FDA has approved several products we call CAR-T products in a different lymphomas. And you see here also exemplify the ones in myeloma, in adult acute lymphoblastic leukemia, mantle, diffuse, and so on, follicular lymphoma, and many more that coming up with different targets and different composition. The next slide, we see that these drugs has produced very responses, excellent responses in the patient. But I think the key message here, is that many of these patients, around 40% of the patient, has durable responses that obviously is still unclear, is going to be cured, but definitely we have follow-up of 5 years, and some of these patients did not really relapse. However, not once again, everyone. So how we can improve or how we can complement that. So the next slide really bring the same kind of concept that we have just seen in myeloma, is the bispecific antibodies, in this case in lymphomas. In fact, we were the first one who really have these products in the clinic, and we've been studying for many years. I think the problem is over time we've been understand how to put together really similar that we have done for 30 years with a monoclonal antibody, is Y structure. But in this case, this Y structure not only recognize really the target cell that we used to do for many years, rather put together these T cells close to the malignant B cells and really produce this killing. You see here, and many of those are really already approved, and some of them in the ways. You see very weird names and very different strategies how you genetically engineer these monoclonal antibodies with sometimes with different receptors, in this case, even like a more recently, no IgG, that is the classical one, or like an IgM, who has much more ways to really encounter the antigen in the B cells, and at the same time, really bring this T cell in order to really have this response rate that you see here in aggressive, indolent, or kind of different types of lymphoma. Once again, some kind of toxicity, but we will see lower toxicity. And what is the difference that we're going to see in a second? Next slide, I just briefly want to review that FDA once again has approved this technology, in this case, really in 2023, glofitamab, epcoritamab, these phenomenal things that have to be given as outpatient. It's a completely different setting, so we are inject something. It's not like we don't need to really get the T cells as we do in the CAR T. It's like the administration of these bites of the biospecific antibody can produce a very successful responses. And in the next slide, this is one in aggressive lymphoma. Also, we can see this in less aggressive lymphoma, we call follicular lymphomas. And you see some of them approved, some of them they're very soon approved. So we have many ways to really understand and really control the disease. So the question in the next slide that really start to discuss is how we learn with these biospecific antibodies in lymphoma, and how you start to differentiate for the CAR T technology, and how we can implement these two phenomenal, really therapeutic armamentarium in the treatment of patients with lymphomas. So again, we know that they can cause this inflammatory response, but not as much as the CAR T. We don't really see much neurotoxicity, and obviously the efficacy, you need to keep really doing that. CAR T is once and that's it. Here you need to really keep giving this substance through the vein or through subcutaneous, right? So again, this small amount of dose that we escalate really mitigate this problem that we see in the patient. So in the next slide, we see finally, and please check it again, once again, right? And the end, please keep going, because I think it's several, keep going. So I think the argument here is, and the question that we are really getting in the clinic, how we use biospecific versus CAR T, right? And obviously you can argue that we have situation, and still is, we study, is better to use before, is better to use after. For sure, we have many people who fail CAR T and happen in myeloma. We use the monoclonal, these bias, and sometimes we rescue, or we can bridge with these biospecific antibody patients who can finally get CAR T, because we now, for now, CAR T is the only technology that has shown this long-term duration. We don't know if it's going to happen with bites. It will be very easy, or will be more broadly applicable. We only can do CAR T, for example, in our institution, but it's very hard to do in other places, while biospecific may be given easily in other institutions, while this also in our institution. So no doubt that the bites can really easily to be obtained off the shelf, then very fast to really give in, and you can repeat it, while the CAR T is more complex, has a different kind of problems to really administer, and also to really treat this patient. In the next slide, I think we just want to really point out that we are been doing a lot of really research in the monoclonal as well in the CAR T. I just want to point out in this case the area of biospecifics that is the novel one, and obviously Dr. Chavez, a pioneer in the treatment of CAR T in lymphomas, also has led several trials in bites in general in non-Hodgkin lymphoma, and Dr. Gavala also is really trying to bring one of the new bites-specific antibodies that is really resulting in a very good data. And obviously we continue in a different combination, as Dr. Shain was talking about, how we can combine different forms of immunotherapy, bites with immunotoxins and other forms of therapeutic approaches. Just to finish in the next slide, just to really go into the translational research part of something that we have been doing in our department for a while. When what we really need for all these therapeutic approaches to work is a good T cells, right? So you see here several T cells with different faces, and I really try to really put in a kind of cartoon way, because obviously we want to really have a good T cell, a healthy T cell. We call an effector T cells. But we know that the diseases, the problems, some therapies the patient receive, and in general the other age and many other things, these T cells maybe start to really get disappointed, disillusioned, looking really, and finally they get very tired. And I think is one of the problems that we encounter, how we really recognize when these T cells are not really in good shape, where the immunotherapeutic strategies that we're going to apply won't work, and how we're going to really be able to rescue these exhausted T cells, or very, very tired T cells, and get them in a good shape so we can really use them for these very, very sophisticated and very successful application. The last slide just show some of the area that's a little more complex. In the next slide, please continue to click, how we really investigate the metabolism. The metabolism of the T cell is a fundamental aspect. We know that cells, like human beings, they need this energy, comes from these organelles called mitochondria, and we study very deep detail the dysfunction of some of these metabolic pathways and how to repair them through intervention in vivo or in vitro, so we can really get better T cells and we can really make these therapeutic strategies more successful. And I think it's the end of my presentation. More than glad to really answer any question that you may have. Thank you very much for your attention.
Awesome. Thank you so much, Javier. That was a wonderful talk and a really nice overview of a complex and evolving topic. And I'm sure we'll have a lot of questions about the role of immunotherapies in lymphomas coming up over the next half hour or so. But right now, I just wanted to take a moment and introduce one of the very important partners to our department in malignant hematology, that being Tyler Wilson. And Tyler is with the Moffitt Foundation, and he works very closely with our Department of Malignant Hematology to help us receive the most research dollars that we can to help really get much of this clinical research off the ground and to help advance the field through many different venues, including philanthropic donations. So if you'd like to learn more about how you can help, if you're interested, please contact Tyler. And Tyler, I don't know if you wanted to say a few words just to that effect.
Yeah, I'd love to. I'll keep it brief. I know everybody's trying to get to the Q&A because there's a ton of questions, but I want to thank everybody for joining the webinar tonight and for the opportunity to be part of this wonderful panel. I think seeing the presentation tonight and understanding really how exciting this time is in cancer research is truly impactful to understand the role that philanthropy had in allowing us to get to this point. I've been at Moffitt now for 4 years, and to hear Dr. Shain say the next generation of cancer research was truly exciting, and I don't think we wouldn't be here without philanthropy. And Dr. Pinilla mentioned getting to opportunities where we don't really know the answer or how these next steps are going to be impacting treatments. And, a gift to blood cancer research, malignant hematology research allows the opportunity for us to understand why and then put that into practice, into real life solutions and develop new treatment options. So philanthropy truly does make a difference, and we can, in this exciting time, really see it happen in real time year over year. So like Dr. Lancet mentioned, if you have an interest in making an impact at Moffitt through philanthropy, feel free to reach out over email or give me a call. be more than happy to address any questions. We try to keep it as simple as possible at Moffitt to make a gift. Certainly any gift to Moffitt makes a difference. But if you'd like to designate your support for Malheme research, you can simply make that designation online or via check by noting Malheme or blood cancer research. So thank you again for the opportunity, and looking forward to hearing the questions in the Q&A.
Thank you so much, Tyler. And yeah, just to reiterate, everybody that works in this department, from faculty to staff, is deeply grateful for the contributions that we've received to date that have really made a difference in sparking some very important research in malignant hematology, both on the basic science end and in the clinical trials end. So this funding is really important for us as an organization to help our patients achieve the next steps in success for their specific types of blood cancers. So thank you, Tyler, for all that you do and for all the foundation does to support our department and all of our patients. So with that, why don't we go ahead and we'll start with some questions. Now, we have a lot of questions that have been proposed already through the Q&A box. Please continue to submit questions. We're not going to be able to answer all of them live, but we will record them and get back to you on your questions if we can't answer them live tonight. And what I'll do is I will basically ask our speakers to address some of the questions that are most pertinent to their areas of expertise. So why don't we start with, I think, an interesting question that I'll pose to Dr. Padron, and that is there any research going on to see whether certain individuals are more or less predisposed to developing clonal hematopoiesis?
There absolutely is. And so researchers from around the world have used very, very large databases and biobanks to answer these questions, like the UK Biobank, which has over 1 million individuals. And the short answer is there are absolutely some hereditary predispositions to clonal hematopoiesis. They're not a guarantee that you will get it, but it would put you at high risk for getting clonal hematopoiesis. Interestingly, there are also hereditary changes that can protect you from clonal hematopoiesis, or at least the effects of clonal hematopoiesis, the adverse effects of it. So this is just an emerging area of research, but there is a component of heredity in developing clonal hematopoiesis.
And then just staying on that topic, we have a question that I thought was interesting, and I'll pose it to you again. So the question is it's been shown that certain myeloma therapies are associated with a higher risk of secondary cancers, including leukemia, namely chemotherapy, I believe this person's referring to. Is it possible that clonal hematopoiesis is playing a role in the development of these secondary leukemias in myeloma patients? And is there a way to screen these patients who have myeloma for CHIP?
There is certainly a way, and we have that test at Moffitt today. In fact, a team that included Dr. Shain, but also Nancy Gillis, who's an epidemiologist at Moffitt, focused on clonal hematopoiesis, looked to see, in banked samples that Dr. Shain was instrumental in collecting, whether clonal hematopoiesis was associated with any adverse outcomes in myeloma. And it was, and not only was it associated with adverse outcomes, it was associated with adverse outcomes in the context of ethnicity. So that African Americans had a worse outcome even more than those non-African Americans with clonal hematopoiesis. So that work is being done. And there certainly is a role for screening myeloma, just like any other cancer, for clonal hematopoiesis.
Great, thank you. And
Can I add real quick, Jeff? Sorry.
absolutely.
Because Eric did a great job in highlighting that. But one of the therapies we use significantly is called high dose melphalan transplant. And If we can use clonal hematopoiesis as a way to learn, is that a risk factor for developing second cancers after? That's one of the things we really need to start thinking about. Is that a way to help personalize therapy? And that's what Nancy and Eric or Dr. Padron are all trying to kind of help us do. But it takes big numbers, and we're all working on it. But it's a collaboration that we need to continue to push forward with. Sorry for interrupting. I just wanted
No, great
put that in
point.
there.
Let me shift the topic a little bit to immunotherapy, and I'll pose this question to Dr. Shain, and Dr. Pinilla could chime in as well. But the question is, if you've gone through CAR T or bispecific antibody therapy that doesn't work any longer or didn't work in the first place, can you still be qualified for an alternative form of immunotherapy, maybe one or the other, if one doesn't work, or something else?
Yeah, it's a great question. I was actually just answering that via typing as well. So thank you. It'll save me a lot of typing. But I mean, Dr. Padilla, please jump in after. But essentially, the answer is yes. Is the simple answer is we've done this, and we know that if you can use one immunotherapy after the other, but it's still not a simple answer, right? We know that certain things aren't really good, and this is data developed at Moffitt by Doris Hansen and others in the CAR T group. Essentially, we know that if you use essentially BCMA targeting bispecifics right before CAR T isn't going to work very well, probably because the target as well as the T cells are being affected. So here we try to sequence CAR T and then use the bispecifics after. And really the key is if you can target something different, it's kind of ideal, better to go back and forth. But we also know time goes into it. If you're early relapse patients, maybe a different target's really important. If you've done really well after CAR T for periods of time, then probably the target isn't important. You can just use the BCMA target again. So the answer is yes, but it's not a simple yes. And again, as you heard me say, that's really why we need to have new targets and new bispecifics that target maybe more than one thing or other targets, so we can start adding these things together, or maybe more interestingly, sequence them along the way. Dr. Pinilla.
So I think Dr. Shain did a very, very nice understanding of the problem. I think in the world of the lymphoma, we have been debating a similar issue. In the beginning, obviously, because CAR T was developed early on and BiTEs came later, we start to have experience to really see effectivity of BiTEs post-CAR T. I think it's still, at least in lymphoma, it's still not very clear if we can do the reverse. In the beginning, we have some data that suggested that May was not such a good idea, but more recently, we have more and more data that really suggest that it may be okay. I think it's all about what we're mentioning in the last slide, how tired are the T cells that we are really getting into what we try to activate through CAR T or through BiTE. So I think, and the timing before the end of these therapies until the beginning of the new therapies, I think is going to play a very important role. And once again, as mentioned, our research is concentrating to see how we can rescue some of these T cells. However, I think, as Dr. Shain was mentioned, it's really, we have a new targets, right? So I think, in the CD19 CAR T classical, now we have CD20, CD22. So as happened in myeloma, in the world of B-cell malignancies, we try to come out with different targets because we know that some of these targets that we initially, use for, they may really downregulate or they disappear from the tumor cell. So there is no doubt there is always really possibilities through commercial or even clinical trials to understand and try to really give opportunity to patients to continue in remission.
I'd like to maybe circle back to Dr. Padron on a question, several questions actually being posed regarding the utility of these new immunotherapies for myeloid diseases such as myelofibrosis or MDS. So, Eric, would you mind commenting on the current state of these cell and antibody-based therapies in myeloid malignancies?
Sure. So, unfortunately, in myeloid malignancies, the results have not been as impressive thus far as they have been in lymphoma and myeloma. And there are several potential reasons for this, all of which are being studied at Moffitt right now. So one of the reasons is that while there may be a good target for the myeloid disease like myelofibrosis or MDS, because of the environment in which these blood cancers like to live, they actually make the T cells or the CAR T cells less effective. So the environment around them makes them less effective. The other reason is, unlike myeloma and lymphoma, there actually aren't very many good targets. And a good target is something that is specific to the cancer but doesn't hurt the rest of your body. So those are the two major reasons why it hasn't worked thus far. Moffitt is using all its resources, from clinical research with CAR T trials to laboratory research, to try and address those as quickly as possible.
Yes, absolutely. And we do have several trials going on right now in the myeloid field, testing different types of CAR T therapy approaches and bispecific therapies. But as you mentioned, Eric, not as far along and not as successful to date. But hopefully that will change with more knowledge in the field. I wanted to get to a question that I think maybe both Dr. Shain and Dr. Pinilla can answer, and it pertains to the role of CAR T and bispecific antibody therapies as initial treatment for myeloma and even lymphoma, and whether you see these types of therapies moving up and becoming more than just salvage therapies. Ken, you want to start?
Okay, I was going to get Javier first, but okay, I'll go. So,
Yep, go ahead.
one, we are definitely looking into this, as I kind of mentioned maybe in my rapid fire discussion, is that we are opening clinical trials where we're using CAR T earlier and earlier in lines of therapy. In fact, in myeloma, again, lymphoma is a little farther ahead because they've been around a little longer. We'll start using it what we call early relapse, hopefully FDA approved by second quarter, third quarter of 2024, because we've had really good phase 3 randomized data saying we can use it earlier and do it safely, and it's better than standard of care. And then from there, we're moving back to, can we do it after transplant to consolidate people instead of transplant, or can we do it with, instead of it altogether, use it in newly diagnosed patients? Those are all things in which CAR T is being utilized. Bispecifics are following the same pattern. They're just a little farther behind. And as I mentioned, we're opening a study here where we're actually looking at bispecifics in smoldering patients. So before they actually need therapy to prevent active myeloma from happening. So a short period of time, they get therapy. So yes, we want to integrate it. That's how we hope we can change the outcomes for patients in myeloma. And I guess, Javier, to your point, you're probably going to say similar things, but I'll let you, expound on the lymphoma side of things.
Sure. As Ken was mentioned, I think the world lymphoma has been evolving since the early approval by the FDA in third line. Then we went to the second lines after the first, failure of chemotherapy. Now already have been well reported. Dr. Chavez has been very, very well involved in trying to really try to find this very high-risk lymphoma with genetic features that really predict poor outcomes after chemotherapy, and try to really see a very early intervention, almost, to really do some kind of very, very brief period of chemotherapy, or 1 or 2 cycles, and if it's not working, really go to CAR T. So there is no doubt we're going to see more and more, and I think historically is what happened in hematology and malignant hematology. When we see something that works very well in third line or fourth line, we start to really moving in early lines, because we believe, and I think lymphoma is taking the lead, and see these very plateau curves, what we call plateau of this survival or progression curves, that patient at some point do not relapse anymore. And this in the long run is associated with pretty much cure. And it's something that obviously we try to implement in early lines to really, try to bring more patients to the cure, and to the fact that we'll hopefully never will really need further therapies.
And it's important to note that we do it this way, right? Late relapse to earlier lines, because we have to be very careful about the safety and efficacy balance, right? So to test it carefully, just make sure it's still positive and better than standard of care and appropriate, which is why it slowly moves. It doesn't just go, it works, let's use it here. We have to be smart about it. That's why both myeloma, actually most cancers work the same way. You start kind of when there's less options, and then as you prove efficacy and safety, move earlier and earlier lines of therapy. So that's why it's probably slower than some people want, but it's also very appropriate to make sure we're doing the right thing with the right information. Just wanted to add that in, Dr. Pinilla.
All right. The bite story is the same, right? As we discussed, they came after the CAR T, but at the same time, sometimes they are easy to implement or a fast way to implement it. So we're going to see more and more data coming up in different types of lymphomas, really bringing these bites technology in early lines of therapy.
So we're going to take it a little beyond the initial stopping time to 7 p.m., try to go another 10 to 15 minutes if people are interested in staying on to answer a few more questions, since we have so many of them and such great topics and speakers. Staying on the topic of CAR T, Javier, one question that often comes up is there an age limit or I guess maybe a frailty limit to what if a person can go through a CAR T therapy, maybe compared to a transplant? Can you comment on whether we have those types of limitations for CAR T therapy in lymphoma, for example?
Sure. We traditionally has put limits in allogeneic bone marrow transplant, although over time we understand that more and more elderly, quote unquote, population by age, by biologically very well fit, can do that. Well, I think with CAR T we are beating even these years, right? We were discussing our tumor board recently that we have done CAR Ts in patient, in the 80s and even in the late 80s, right? Once again, I think physical condition has a very, very important role of the final outcomes of this patient. But I have to really say, patient in some cases with not really as good physical condition, maybe sometimes they may really require a longer time of rehabilitation, but they are being successfully putting through this procedure. So for sure, overall, it could be toxic, but definitely less toxicity compared with an allogeneic bone marrow transplant. In some cases, extremely successful even in this elderly population. So we don't really typically make any kind of threshold or any cutoff or say, well, you are more than 85, you cannot really be a candidate. No, we evaluate the physical aspect, the biological aspect, and obviously comorbid condition. And even with some of these comorbid condition, we are being successfully bringing patients through these therapies.
I guess the message really is that it's potentially appropriate for all patients and that it's worth getting evaluated for to see if it's an appropriate treatment. Let me go back to Dr. Padron briefly here. A good question about clonal hematopoiesis and whether outside environmental factors could increase the likelihood of clonal hematopoiesis and secondary cancers, such as chemical exposures. Agent Orange was mentioned in the question, maybe others as well. Could you comment briefly on that?
Sure. Short answer, yes. Environmental factors we think are a major driver of clonal hematopoiesis. And the reason we think that is because ultimately, if we look deeply enough, all of us have clonal hematopoiesis mutations in our blood. They're just at so very low levels that current tests can't detect it. So it really isn't a matter of how to prevent them from occurring. It's a matter of preventing them from expanding. And a variety of exposures have been associated with that. As I said earlier, chemotherapy, radiation, smoking. And what's interesting is that a lot of these triggers are linked to not just clonal hematopoiesis, but specific types of clonal hematopoiesis mutations. And other things which have been demonstrated to be associated, which are inflammatory conditions, even obesity. So we think not only do environmental triggers make it more likely to get clonal hematopoiesis, but we think they're the major research area where we need to identify them and mitigate them so that things don't develop into full-blown cancers.
Thank you. And back to Dr. Shain briefly. There have been a couple of questions about the utility of immune therapies that we've been talking about in some of the non-myeloma plasma cell disorders, such as Waldenstrom's and also amyloidosis. Could you comment on whether there's been any research into these particular disease subsets?
Yeah, it's a great question. So primary amyloidosis they're both very rare conditions. And Waldenstrom's, honestly, we kind of lump more in the lymphoma side. So the targets might be more aligned with the lymphoma targets than they would be with the myeloma targets, because they're going to have those kind of markers along the way. And so they kind of sometimes gets wrapped up into the indolent lymphoma packaging in terms of investigation. For amyloidosis, there is data. The trials aren't as, I haven't seen published data for trials to date with CAR T or bispecifics, but there are things that are ongoing. And I can say from a practical perspective, at Moffitt, we do probably more CAR T and myeloma than any place in the country. And we've done it in amyloid patients, patients with myeloma and amyloid. But again, you can imagine amyloidosis patients have a different set of side effects depending on the organs that are involved. So there's a little bit more in terms of what you have to, the thresholds to get CAR T and or bispecifics. In fact, I just saw one today who has amyloid, who just went through CAR T. She's progressing and she's going to go through bispecifics. So on a practical nature, yes, we can do those things. So I'll kind of answer it that way.
And a question for Dr. Pinilla, I guess a little bit along the same lines, if maybe you could comment on the utility of CAR T therapy and maybe bispecific therapy on some of the other lymphoma subtypes, such as follicular lymphoma or I think Hodgkin's as well.
Hodgkin and marginal zone, I
Marginal
think.
and mantle cell, yes.
That's correct. Yeah. So for sure, the initial approval for CAR T was a diffuse large B-cell lymphoma. I put it as example of the more aggressive lymphoma that we see. But shortly after, we start to really see, or we saw the approval of mantle cell lymphoma. Then after that, follicular lymphoma. We see some cases of marginal zone, although it's a little more confused because marginal zone was part of the initial trials. But some of them only have to be transformed. They have to go from more low grade to more aggressive way. And finally, the Hodgkin. The Hodgkin is one of the areas that we are very actively investigating, and really we hope that we really open a trial specifically for Hodgkin. We do have a very, very nice therapeutic for this condition. We know that can be cured in a relatively high proportion of patients, but we still see patients who relapse no matter what, with even very, very nice immunotherapies that already been used typically in metastatic cancer, like a PD-1 inhibitors. So there is no doubt that it still is not reality right now. It's in clinical trials, but it's a very, very high hopes that we will really bring another strategy to Hodgkin, as well as a chronic lymphocytic leukemia, one of the orphans kind of status in this condition that obviously happen in older population. There's been trials done of these, but it still is not really prime time. However, we hopefully in the next 2-3 months, we may have the news from FDA to accelerate approval of one of these technology for CLL. We continue to work on clinical trials. So for sure, we're really expanding the histology. As I mentioned, lymphoma is a quite complicated entities based on the different types. Obviously, I didn't mention T-cell lymphomas is another area that also very actively investigated through BiTEs as well, T cells, CAR T cells. So we will see much more in the next years.
Thanks so much for that comprehensive answer, as always. Going back to Dr. Padron, maybe if you could say a few words. We have a couple of questions on the topic of MRD, or measurable residual disease, and what triggers that test to be done on, say, a bone marrow biopsy, and what the results might mean. Can you briefly comment on that particular question, since it's such a hot topic?
Sure. So maybe I'll start answering that by defining what we mean by MRD. So MRD means, depending on who's defining it, minimal residual disease or measurable residual disease. And so basically what these tests do is they aim to detect the very, very lowest levels of cancer in one's body, to really see if it's completely gone, or at least gone to the point where these very high sensitive tests can detect. And so with that in mind, as you could imagine, what would trigger a doctor or your doctor to order that test is when the expectation is that most of the disease is been eradicated, and that it will not be detected with conventional methods, whether that be a pathologist looking under the microscope or non-MRD genetic testing. And so the way that I always talk about it with my patients is to imagine the fact that maybe in lung cancer, it's a little easier to imagine. But generally, for a radiologist to see a lung cancer mass, there needs to be 1 billion cancer cells there just to be able to detect the smallest mass. So MRD are tests that try to get to a level that's better than that we're not just going to be waiting until 1 billion cells come up. And in blood cancers, generally the threshold for calling a test MRD is its ability to capture 1 in 1 million cancer cells. So if you have 1 million cells and out of that only 1 cancer cell is present, that MRD could detect that type of test. So that's a little bit about MRD and why someone would order it.
Great. Yeah. Very, very interesting topic. And I think one that has kind of emerged as one of the main determinants of future therapy and the success of the treatment that had been just received. So we're still learning about how to intervene with MRD, as Eric mentioned. But once we do that, it'll be a very powerful tool to help guide therapy, even more so than it is today. I'm just going to go a few more minutes here. And Javier, one question that came up was, how do you determine the health or the condition of T cells, which might influence the utility of, say, CAR T therapy or bispecific therapy for that matter? Are there ways to, I guess, identify T cells that are more or less likely to be responsive, I guess, to this type of therapy?
It's an excellent question, right? I think we don't have a complete answer. I think we really start to characterize certain subpopulation of T cells, sometimes relatively small, that they really predict good outcomes after CAR T or even BiTEs more recently, right? But we don't really have, unfortunately, an easy way to really do this in a clinical setting, right? Most of these data come from research, sometimes retrospective research that has been done in samples obtained for patients who really were under CAR T or BiTEs, and they really start to predict which patient respond, and based on that, what kind of characteristic of T cell. So sometimes it's like as simple as surface marker of this T cell that really make them certain characteristics we call, and it's very well reported, the stemness. The stemness means that the more early progenitor of T cells, or the more early T cells, naive T cells that we call them, may play a role, because this T cell has the capacity to grow once that they encounter the tumor. But also, as mentioned briefly at the end of my presentation, metabolically is fascinating how these T cells use glucose, lipids, and other kind of factors in different ways, depending on the stage and depending on how much treated has been the patient, or the what we call the tumor microenvironment. So it's something that we are really investigate very, very heavily and very deep, but we don't really have an easy way to really answer this question right now in the clinical practice yet.
Thanks. Yeah, no, it's a complex question, but certainly one that is going to be important, because not one size will fit all. And there will be patients who are more or maybe less appropriate for therapy with T cell based approaches, or T cell engineering, or bispecific antibodies for that matter. Let me ask Dr. Shain, as we finish up here, any thoughts as to the role of off-the-shelf T cell therapies, CAR T therapies, as opposed to autologous therapies, and when they might be more appropriate, and whether there's certain indications for that.
Yeah, I think Jeff, that's a great question in the audience. That's a great question because, as it kind of implies, right now CAR T comes from yourself and you have to manufacture, and that takes time. It can take weeks to do, and obviously your myeloma doesn't always behave when it comes to weeks without therapy, and it becomes a little bit more challenging. So there have been studies that have looked at ways we could use CAR Ts made from donors, so off the shelf, just give the CAR T to the individual. So far, at least in myeloma, they haven't been as effective, and we're not sure why. If it's dosing, it's early. If it's T cell fitness, we're not sure. We're also looking at ways in which to shorten the time of manufacturing. So one of the trials that we have going here, the DDBCMA CAR T, is essentially a way to make it faster. And the hope is that the next generation will be 2 weeks versus 4 to 6. Now, in myeloma, it's really 4, 6, 8 weeks. In lymphoma, they have ones that are a little faster already. I think in the 2 week range already, right, Dr. Pinilla?
Yeah,
But yeah, the goal was to do it a little faster for sure.
yeah, there is accelerated CAR Ts and also from autologous, but the area of allogenic CAR T is very well investigated in lymphomas. There is several trials that we are being performing is currently in our institution. It still is unclear. I think one of the important aspects of the allogenic is very easy to really find them, but the persistence is not there, right? It's one of the areas that we see in the autologous. The autologous CAR T can really stay longer period of time in the body of patients, and they may continue to redo the effect once after the initial encounter with the tumor, right? Where the allogenic is more like a quote unquote chemotherapy through immunotherapy. You really deliver these large dose of T cells, they kill whatever need to kill, and then after that they really disappear. I think the argument is maybe this reaction can elicitate some secondary immune response by the body, but it's unclear and it's still under very, very heavy investigation in clinical trials. The same thing with the NK. I saw some question about in the chat, some patient asking about what is the status of NK technologies or NK CAR T. NK in general is another phenomenal, tool, but it's still on clinical trial. Is not prime time. We continue to really investigate what is the areas that we can really intervene with these new type of cells.
Agree.
Well, I think in the interest of time, we could probably go on for another couple hours here. There's a lot to talk about and a lot of great questions. But we're getting late into the evening here, and I think we're going to wrap it up. I've been told that we will be able to keep these questions or memorialize them in a way that will allow us to follow up with these questions that have been posed. I'm sure that our staff will be able to help inform anybody that has interest, but we will make every attempt to answer every question that's in there. There's still a lot of questions about individuals' personal situations with regard to their disease, which we'll try to answer in the coming days. But I'd like to just finish by thanking all of our speakers, Doctors Padron, Pinilla, and Shain, for great presentations and great dialogue. I'd like to thank Brielle Humphreys and Stacy Price for their help in putting this together. You guys did all the work, and we just sort of showed up here to answer questions. So thank you for a really wonderfully orchestrated webinar. And thanks, of course, to Tyler Wilson, who's been just such a great partner in putting together programs for us with the foundation and helping connect us with potential donors and helping us to advance the field. And I think with that, again, thank you to the audience for everybody that joined us tonight. Great questions, really thought-provoking ideas that give us pause and make us think about what we need to be doing differently as well as physicians and researchers. And so we very much appreciate all of your support as we really try to move the needle here with blood cancer care and improve the outcomes for our patients. So with that, I think we'll call it a night, and thanks again to everybody for joining, and we'll do it again soon.
Have a good
Night,
night.
everybody.
Take care.